think about the concept of newborn screening and if SCID meets those criteria. So some of the criteria for newborn screening is that the prevalence of the disease has to be greater than 1 to 100,000. And that is absolutely the case for SCID. And in fact, this number here may be dropping. SCID is probably more common than we ever thought it was, amenable to newborn screening. Can this disorder be detected by routine physical exam? No. I already told you, these babies look completely normal at birth and can stay healthy for the first few months of life. Does the disease cause serious medical complications? Well, I think I already showed you already know, and I showed you some data that this really is uniformly fatal if not treated within the first several years of life. Is there a cheap, sensitive, and specific screening test? Yep, that TREC assay is the winner. Is there a confirmatory test? Yes, there is. And what we will be doing here at Iowa as our second-tier test is lymphocyte subset analysis via flow cytometry. And does early detection improve outcomes? Absolutely. And again, I showed that earlier, both with respect to survival as well as cost. You can really decrease overall mortality and morbidity from SCID with early recognition and early treatment for that. So TRECs are now being recognized as the surrogate marker for T cells, and you can use dried blood spots, blood obtained from dried blood spots on newborn screening cards to actually get the DNA material that you need to do the PCR assay. Although some of the initial studies done looking at TRECs as a marker for newborn screening, which were done by Chan and Puck and published back in 2005, the false positive rate that they had at that time was about 1.4%, unacceptable for newborn screening. It was Dr. May Baker and her colleagues in Wisconsin that worked rigorously to perfect the TREC assay, and now the false positive rate is less than 0.1%, thus making it an acceptable test for newborn screening. And there is also very little need now for retesting. We'll be able to do the TREC screening after that dried blood spot has been collected shortly after the baby is born. A flow and an algorithm in place that if 0 or low TRECs are detected on our TREC assay, that we have a means to notify the primary care physician and also contact the parents. We have second-tier testing in place, which again will be flow cytometry with the CBC and differential, and arrangements are underway to make sure we get that sample for second-tier testing delivered here to the flow lab at the University of Iowa within 24 hours. And then if our second-tier testing is abnormal, we will be working to get these babies here for further evaluation and more definitive diagnoses.